You're listening to Aging Uncensored.
Hello, and welcome to Aging Uncensored, the podcast where we fearlessly delve into the unfiltered realities of growing old and navigating the world of caregiving for our beloved seniors. I'm your host, Christy Baines. I have my co-host here, Nicole Crawford. We have our producer, Taylor Crane, and we're super excited to announce LifeCare Solutions' newest and only Chief Clinical Officer, Chaeli Lawson. So we're going to be diving in today with Chaeli's background and how she has joined our team and all the things that we're really excited about in 2025. So grab your cup of coffee. Usually Nicole and I are cheersing. And buckle up as we embark on a journey that explores the highs, the lows, the laughter, definitely the laughter, tears that come with the aging process. So we're going to just jump right in. Okay, let me give a little bit of a snippet about Chaeli. I'm going to read a little bit of her bio, and then I'm going to really dive into what's more important, which is how cool she is. So Chaeli has more initials after her last name than any of us. I'm not even going to attempt to go through all of these. But the key is she has been in a nurse practitioner since 2014, so going on 11 years. She is an adult geriatric primary care nurse practitioner. Her background includes geriatrics, palliative care, hospice care, nephrology, home care, all the things, right? So when I got the opportunity to meet Chaeli, she was the lead nurse practitioner for UAB Geriatrics Clinic. She also helped run their House Calls Clinic. And she truly has been kind of my sidekick in a lot of times when we were working with patients that we shared. And then more importantly, when she walked me through helping my dad, my aunt, and most recently, my sister-in-law. So I called Chaeli a super close friend, and now we're so excited to have her on board. I don't know about okay, everybody unmute because I want all this excitement.
Yay!
I mean, in the last 2 months, yay! With Liz joining us, Liz Klein, who's our new counselor, and we've got LCS on the move going, and then Dr. Duxbury, Andy Duxbury, and Chaeli joining us on December 2nd. The excitement that's going around LCS is just, I don't know. It's really cool to kind of come in the office and see what's going on and how we troubleshoot with one another. So that's my cheer for the day. Anybody want to add in, Nicole?
I just want to say that I have adored Chaeli from the first moment that I met her in the geriatrics clinic many, many years ago. She's always calm, powerful, knowledgeable, all of the things. And she has the most beautiful skin. And everything about her, I just want to be her when I grow up one day.
That's right. That's right. Now, Chaeli, don't let us down, right?
I know.
We've set you up here.
Yeah. Well, thank you all so much.
You know, one of the things we asked Chaeli, and when Nicole and I did our first episode, we talked about our why. Why did we get into this? So I know I didn't prepare you for that, but what's your why? Why'd you do this?
Yeah, so my why is I think I've always had this just innate sense and purpose that I want to help people and improve their lives. And I think that getting into geriatrics was just second nature to me. When I was a little girl, I spent a great deal of time with my grandmother, and she is just an incredible person and does so much for so many others. And I remember being a little girl, and every Sunday we would go after church and visit people who were in the hospital or who were homebound and unable to get to church, or even caring for really elderly, frail folks who had no one. And she just did whatever they needed, whether it was take a meal or go to the pharmacy or call someone for them, whatever. And so I really was alongside her, and she was sort of, I think, the first geriatric care manager I ever met, even though she has no official title. And so I think that just helped drive my love for older adults and helping them navigate this crazy healthcare system of ours as they age, and just making their lives better. So I credit a lot of my why to my grandmother.
Absolutely. She was hip and doing the whole geriatric care thing before that was actually a thing, right?
Yeah,
So
certainly.
you have to tell us some of your funny stories about your grandmother and her calling you for medicines and all sorts of things like that.
Oh, gosh. My grandmother is the most precious woman, and she's equally as fierce and powerful and stubborn as you would expect. And so there's been a lot of heart. She's caring right now for my aunt who has dementia, and she's doing it beautifully. I know she doesn't always feel that way, but there have certainly been some heart-to-heart conversations over the years about over the recent years about things that maybe she needed a little bit of advice on, but didn't realize she needed the advice. So, but fortunately, we have a really good relationship with each other. So
That's great. That's great. Okay, so obviously that kind of led you to where we are now. What would you say is, I guess we're going to go with a couple of different questions, but the first one is let's just go back to like the geriatrics clinic. When somebody was coming into the geriatrics clinic, and typically people aren't thinking about going to the geriatrics clinic, like leaving their internal medicine, their other primary care doctor or things like that, unless there's something that might be going on. What were some of the first things that you wanted to explore with that patient and maybe the family that you think is super important for, anybody as they're getting into the world of caring for their older parents or their older spouse or friend and aunt, grandmother, whatever?
yeah, so I think when patients were coming into the clinic to see me, often they weren't by themselves. So they were often with a family member. And one of the first things I really wanted to understand was the dynamic between the family and the caregivers and the village that person had. And sometimes they didn't have a village. But understanding the support system, on a surface level. And then as time goes on and we delve into things, understanding, more deeper dynamics of those relationships and how they function and how the caregiver is caring for themselves, or are they at all, or do they even know to do that? Or do they have a family outside of this, responsibility to their parent or loved one? And I think understanding that at a core is so important because it's going to guide how you provide care to these people. Not every single plan of care, medical plan of care, is going to work for every single family and caregiver. If you've got a daughter who's 40 and has, teenage children and working full time and trying to, you have to be able to come up with a plan that's for her mom that's going to suit her as well. Like, these caregivers and family members, they have lives outside of this and they have purpose outside of this. And so helping them maintain that, I think is so important. And I think that was one thing that we did at the Geriatrics Clinic was really understanding that and trying to work with it, that you wouldn't necessarily get in like a traditional internal medicine clinic. So,
right. I mean, I think that's a huge takeaway for everybody. One, we get asked the question, should I go to the doctor's appointments with my mom? You just answered that. Yes, absolutely, you should.
Yeah.
And you really need to strongly encourage your, older loved ones to allow that to happen. That's huge. I mean, you didn't dive into what are their labs, what are their, those kinds of things. You dove into what's most important, which is what's their support system, right? And what that looks like. And I think that is such a huge, go ahead, Nicole, jump in anytime.
I also think that the geriatric clinic, and this has helped me with care management, of one of the very first questions at the geriatric clinic, whether you're there for primary care or consultation or just what is your goal for your life? Like, what kind of life do you want to have? Do you want aggressive treatment for everything that comes along? Do you want more palliative treatment? Picking and choosing what's important to that person. And then from a medical perspective, looking to see what can be done to help that patient get to that goal.
Yeah, absolutely. Absolutely. That's a good question there. So your goal, what is your goal? We know your support system now. What is your goal? And talk us through, because we know this in doing this on the care management side, but talk us through the conversation about palliative. When we had Dr. Geldmacher on here, he talked a lot about when someone living with dementia is moving into moderate and advanced stages, medications aren't turning back time. At that point, you're looking at medications more for symptom management and things like that. And it's more of the environment, the behavior, the social support, all the things we just talked about, goal for life, the dynamics, who's helping, those kinds of things. And some of the toughest conversations we have is when we start talking to family members about when to provide palliative care. What does that look like? Doesn't necessarily have to be the H word, the hospice word, but, a lot of times those that are at the geriatrics clinic, and really the majority of the time that we're working with folks, they have a chronic illness that's just going to progress. It's going to progress. Yeah. We may keep them at some level for a little bit, but it's going to progress, and that's what's going to happen. So kind of talk us through what that looks like when you're having a conversation from the clinic perspective.
Yeah, certainly. I think in an ideal world, by the time you're having those conversations, which is going to be early in your relationship with the patient, understanding what their long-term goals are. And I think when you have a good foundation of understanding the dynamic of the family and how that unit works and operates, it helps you move forward with helping guide them through the decision-making process about how to guide their care. I think the first thing to understand is sometimes differentiating palliative care and hospice care for patients and individuals. And the majority of the time, I would say that people don't know what palliative care means. And essentially, palliative care means you're controlling a symptom. So, and it can be done for anyone who has a chronic illness, an acute illness, a curative illness. So if you have cancer that is treatable and the prognosis is good, you may still have some symptoms from that treatment. You may have nausea or poor appetite. And so treating the symptoms to improve your quality of life. So treating that nausea or treating that poor appetite, whether it be with medications or non-pharmacological things, like that's really what palliative care is, put very simply. Palliative care gets tied in with hospice because hospice is where we provide comfort care at the end of life. And that involves palliative care because we're treating symptoms, we're treating pain, we're treating nausea. We're treating any symptom that they have that causes them distress. And so palliative care can be provided to patients who are still at a point where they're seeking curative treatments. That's very appropriate. And it can be provided to patients who are not necessarily seeking curative treatments, but they may have a chronic illness, whether it be dementia or heart failure or chronic kidney disease, any of those where they're creating symptoms that affect their quality of life, but we're really focusing on controlling those symptoms. And so I think that in the conversation, when we're having that conversation and deciding how to proceed, I always encourage the patient to, your Northern Star should be what's most important to you. You know, that's when you are making a hard decision about your medical care, anything in your life, like look at your Northern Star. Like at the end of the day, what's the most important thing? And a large amount of people say, I want to be home with my family. I want to be home with my family, all my loved ones around. I want to avoid facility care if I can. I want to have the support that I need. And so I think oftentimes is focusing on that Northern Star, helping them understand their current condition and prognosis, and then guiding them towards a decision. And oftentimes, once a patient understands condition, prognosis, those things, we can talk about, because if you say, well, tell me what your goal is. Well, everyone's like, I don't know. My goodness. Like, I thought that's what you were going to tell me, you know? But once you know them, have that relationship, and you can help them understand the condition and the prognosis, and then you as the clinician or provider or anyone, care manager, anyone involved in their care can help make a recommendation based on what you know and where they want to go. And so in my experience, I think it's really good to be able to have that kind of rapport and communication skills with patients and families, and just help guide them to that. I think palliative care is probably something that's highly underutilized, just in general, and just largely misunderstood. And so I love the fact that I get to talk with people about that and help them understand it better. And then, you know, I say this for myself, when I know better, I do better. So when you know better, you do better. And you can spread the word. You know, people who are caring for loved ones like this, they often have other friends or contacts that are in the similar walks of life. And so I think that the word can be spread through our patients and our families.
Absolutely. Absolutely. I love that. Know better, do better. That's going to be one of the clips that we take out of many clips that we'll have today with Chaeli. So Chaeli, what has been, I'm going to throw you a curveball. And there may be several. I mean, Nicole and I can sit there, Taylor can too. We can all sit there and think about our most challenging obstacle situation that we've handled. Some of them could be personal, right? Some of them could be, you know, clients that we've worked with and so forth. What's been one of your most, and you know, you can kind of couple it, but thinking on your career, what's been one of the most challenging situations you've had? And how did you tackle it?
That's a great question. I think in general, there's been a lot. I'll say one that comes to mind. And so I like these kind of situations, like in my brain, when we're approaching a situation, like there's always a solution to everything. Like it may not be the solution we think of first, but there's always a solution. And so recently at a previous job, I had a situation where I had a patient who was very chronically ill, on dialysis, very, very sick, and had been in and out of the hospital a tremendous amount in the last year. And hospital rehab, inpatient rehab, hospital rehab, just kind of bouncing back and forth, significantly had affected his quality of life. And it's tough when a patient's in a facility to, especially for rehab care, to coordinate with that facility and kind of there's so many people involved. He had dialysis providers, and then he had the providers in the facility providing rehab care. And it was very like convoluted and complex. And it was a challenge to get everyone on the same page. But fortunately, I was able, alongside my team, to initiate contact with that facility, come up with a plan for the patient, and work with a local hospice agency. The patient had expressed that he wanted to go home and stop dialysis, and he was perfectly capable of making that decision. And he certainly understood the consequences of that, and felt that it was time for him to do that. So it took some time and a good deal of effort, and lots of communication and back and forth. But eventually we were able to get everyone on the same page and get that patient home, initiate 24/7 care, had hospice, helped him just peacefully transition, which was what he wanted. And so it was challenging in the sense that it wasn't necessarily the norm. He had been in and out of rehab, and I don't know if anyone had ever really discussed with him, like, really, what is it that you want to do next? And yeah, he's someone that, palliative could have been initiated previously. And I don't say that to point fingers at any medical provider. I don't think anyone did anything wrong in that situation. But I think that we oftentimes, just as healthcare providers, kind of just get stuck in the loop a little bit, like going through the motions, filling out the paperwork, sending it, without stopping to think sometimes, what is it that we're really doing here? And have we actually talked to the patient about what we're doing? And what does the trajectory look like here? And have we had an open conversation about that? So that was a really challenging situation. And fortunately, we were able to overcome it. And at the end of the day, like, my goal is to always approach a problem with a solution, being solution minded, and then doing what's best for the patient and their family, no matter what that means. And so we were able to.
I think too, taking the time to just look ahead and think about what are the outcomes for the things that we're doing. And I think so often in medicine, like you said, Chaeli, we just kind of go through, well, this is protocol, or this is standard of care, or this is, something else, and it just gets done. And nobody really takes the time to look and see, do I want to be on dialysis for the next 10 years? Do I want to be, whatever it is, in and out of facilities or things like that, without actually taking the time to be uncomfortable to say, what do I want 6 months from now? What do I want from this situation? What happens if I have a client that I went and saw last week, and she's got Parkinson's, and she was telling me how horrible it's been lately with an adjustment of medicines and not being able to walk and falling. And she was very uncomfortable with the question of, have you talked about with your family what happens when you can't take care of yourself at home alone, or what happens if you can't walk anymore? It was very foreign to her to think about what comes next, or to be uncomfortable with those ideas. And I think all too often people just would rather not think about it and say, oh, I'll handle it when it happens. So it throws you into situations that you may not want, because you didn't want to take the time, or your family didn't want to take the time to think about it previously.
Yeah, you're right, Nicole. I mean, I think that that's probably the biggest challenge for all of us, is because we've been doing this for a while, and we can kind of project what this looks like ongoing. But the family and that person in the moment, but particularly the family, we as a culture are geared to fix the problem. And our healthcare system is built to fix the problem. Well, we've fixed problems in a sense that where people are living a lot longer, but then we don't come to the reality that, as we live longer, we're going to be more susceptible to other things that are going on. Hence, that's where we are, right? I mean, the four of us wouldn't be doing what we were doing 35 years ago, 40 years ago. Really kind of us getting into this in the 90s was kind of the early thing, right? We've seen how this has evolved over the last 3 decades, and it's the norm for a family to feel like they are failing their person, they're giving up, all of those things. And then we can get frustrated as their clinician or their care manager or their loved one when we recognize that maybe their doctor at the time is not willing to have these conversations, and they keep, throwing more pills at them or throwing more tests at them. I can remember a situation when my dad was in a hospital, and Chaeli helped me tremendously, but my dad was in a hospital outside of Birmingham, not, about 50 miles down the road. And instead of looking at just simple things, this particular hospitalist wanted to test everything, do multiple CTs, maybe do an MRI, do all these things when all that was needed was just a basic metabolic panel and looking at particular meds that he had to take because of mental illness. But they were throwing all these things at him. And I think that experience is what most people deal with, right? Whether it's, the primary care physician that doesn't really want to tackle some of these chronic illnesses, and it's more about fixing a problem, trying to throw things to fix a problem, or we're going to do all these tests or whatever it is. I mean, diagnostics are super important, but sometimes you have to get back to the basics. And I think that that's what's lost a lot of times.
Yeah.
And so, we can kind of be met with families thinking that we're giving up on you, when no, we're just looking at the big picture and what this looks like. And
Right.
I think if we go back to the 2 primary points that Chaeli and Nicole brought up in the very beginning, which is what are the dynamics and the support system of this person, and what are the goals from that person? If that person has capacity to talk about their goals, and here's a question. What if as a clinician, you're looking at this situation and you ask the goal, and the goal really is not, it's not realistic. So for example, my loved one has moderate advanced dementia. Let's just go moderate dementia. And the family says, well, I want pills to make his memory better. Right. So that and let's say he's like, this is usually the person with moderate dementia is not necessarily saying that, but let's just use that one as an example. That's the goal. So that's an unrealistic goal. Right. So it's like, how do we then steer the conversation to make it more of a realistic goal?
Yeah, I think that you have to, I think number one, it's wonderful that they told you that, because it tells you a tremendous amount about where they are, and like dealing with a loved one who has dementia is a grieving process, because you are grieving so much. So much is lost before they're physically lost. So I think that gives you a good understanding about where they are. And I think that it has to be done in a way, there's acute situations where you're going to have to be compassionately frank, as I like to call it, and sensitive. Like, you do not want to respond in a way that's, harsh or judgmental by any means. And then there's going to be opportunities as a clinician where you're afforded more time, where the situation is less acute, where that family is, and that over time you're going to have to work to help them understand where the patient actually is. Sure. And, you're going to have to help them through the grieving process. You're going to have to, provide therapeutic listening and education and ongoing support and, resources outside of just you as the clinician. So, I think always recognizing that sort of response from a caregiver or family member as coming from a place of emotion and a place of grief and not a personality flaw, not a representation of their own knowledge or cognition or intelligence. Like, it has nothing to do with that. It's all from a place of emotion, and recognizing that and approaching it in a way that's kind and compassionate is the best way, because you also need to be able to build a rapport with that caregiver and family member. And if you tell me that and I respond, well, that's not true and that's never going to happen, so you might as well get used to it. Well, my goodness, like, they're never going to want to see you again. So I think just always remembering compassion and grace is what you have to extend to these people, because, they're grieving the loss of their life. So
Chaeli's already using our core values, Nicole.
I heard her on the phone the other day with a client's family member that she had never met. They don't live in town. And she used all of those things that she just talked about in the call. And I got to overhear them and her validate that person's feelings, her give education of the dementia process, and how that person's so far along that what the family member was asking for really wouldn't benefit that client in any way. And she just kind of handheld and showed so much compassion during that call that I just got tickled that I got to even just listen in, and it just made me excited to have Chaeli on our team and to get to be here and to learn from her. And it just reminds me so much of why we do what we do and why we're all so good at it. And it's because of people like Chaeli. So
Absolutely.
thank you.
So, wow, this just kind of lobs up the ball to where we're going. So, Chaeli, I courted you for a while. Tell me what's the big goal here? So, what's going on in 2025 that we need to be excited about?
Yeah, so in 2025, LCS is going to be implementing the GUIDE program through Medicare, which it is a guiding and improved dementia experience. And it is a formal and robust care management program to provide support to those living with dementia and their caregivers and family. And these are for traditional Medicare beneficiaries, although we are hopeful that we will be able to offer some services to those to other plans in the future. But for now, traditional Medicare beneficiaries. And this is super exciting because nothing like this has ever really happened. Well, there has never really been a robust case management or care support through Medicare for patients with dementia that I'm aware of, Christy, unless you know something I don't know. And as a clinician, previously, looking for services for patients living with dementia, of course, there were outside services. But we're excited because we feel that this is going to have a much larger impact on those that really need the care. So that's what we're doing in 2025.
Absolutely. So we get to start accepting patients for particularly the GUIDE program on July 1 of 2025. So a lot to come over the next 6 months. We will have our own podcast just about GUIDE, but a couple of things. There are only 3 providers approved in the state of Alabama, and we are the only provider that really, we call it Coleman to the coast. So, we will start the rollout in, kind of the central Alabama area, counties surrounding, east to west, north to south from Jefferson County, and then obviously east to west, north and south of Lee County, our Auburn Opelika office, and then continue to grow as this program is an 8-year model. It'll be a 7-year model for us. So super exciting. And that's the reason we are blessed to have Dr. Andrew Duxbury as our medical director and Chaeli as our chief clinical officer. And we wouldn't be here without Dr. Richard Powers, and we'll have our own multiple podcasts with him. I think the name of that podcast is going to be, Have You Heard of the Guide Model? Because here we are. I'm super excited, but it's all the things that particularly all of us on this Zoom have done. When Chaeli was describing how she was talking to the individual with dementia, and everything she said is basically what this model does. It's taking the time to provide support, education, resources, obviously to the person living with dementia, but even more importantly, the person that is the family caregiver. So we're really excited about that. And anyway, that's more to come, right? I get all excited. I might start doing cheers. Y'all don't want me to break down to 1994, Christy, with, my curled blonde hair and the ponytail and bow. I'll spare you that. Anyway, Chaeli, you will be on even more. So just delighted that this is kind of our breakthrough podcast with Chaeli. At some point, we'll also introduce Liz, that's our counselor, and talk about her experiences and things like that. And again, more to come, but super glad that we've got an incredible resource right here. I mean, literally 2 offices for me in our same hallway here. So excited. So more to come. And we hope that you enjoyed this series of our podcast, introducing Chaeli. I don't know what our title's going to be here. What you got, Nicole?
Oh, I just want to ask Chaeli, you
yeah.
are such a dynamic person. You've got 2 kids, you've got a husband, you help your husband's father, you help your grandmother. Tell us how you do it all. And are there any tips or strategies that you have that?
Oh, you're prepping us for the next podcast, Nicole. Thank you.
So the thing is I don't do it all. I have good support from my husband and my family, and I delegate things when I can. And, I always just try to remember what's most important to me at the end of the day, my Northern Star. And if I remember that, I seem to get the other things done. So one day at a time.
One day at a time.
Thank you, Chaeli. Thank you. Thank you for that, Nicole. So I know everybody liked this. So subscribe. We're on Spotify, Apple Podcasts, YouTube, all the things. So share, subscribe. Taylor's going to get on to me if I didn't plug those things in. So more to come. And thank you, Chaeli. We're super excited.